We are going live now.
All right, good. We have, that's fine. And then you are streaming on Facebook, so we're good there.
Yeah, we just went live on Facebook and now I will start the recording, or you started the recording. Okay.
It doesn't matter. I can start it. Oh, wait, you already started it, right?
It appears someone started it, but it's a mystery who it was. I'm going to say
Um,
record to iCloud. Here we go. We're good.
all right. I think we're good there then. Do you want to just go ahead and drop off then?
Yeah, I'll just stay here in the background just for a second.
All right, that's fine. Okay. Bill, thank you for doing that. Amy Teal, if you're on, thank you. I think we're in good shape. I want to welcome everyone this evening to PA Lyme Resource Network's first virtual Lyme impact session of the new year. We were fighting technical difficulties for about the last hour, but we think we have it down. We are live streaming on Facebook. We are recording on Zoom. When this is done, it will be posted to PA Lyme's website. Typically, what we do when we live stream to Facebook is we do take questions through Facebook. We're not able to do that this evening. So, from a housekeeping perspective, the way that we're going to run the evening is when Dr. Aucott is done with his formal presentation, we will then go to Q&A. So if you have any questions for Dr. Aucott, please ask them in the questions section of Zoom. We'll gather all of those and then we will ask them his questions towards the end then. So as an introduction, I'd like to introduce myself. I'm Eric Huck. I'm the president of PA Lyme Resource Network. We're really very pleased to have Dr. Aucott with us this evening. What I'd like to do, though, is take a couple of minutes and just do a quick recap from last year, as well as give everybody some dates of upcoming events of what PA Lyme is going to be hosting upcoming. So with that, I'm going to do a share screen. Okay. And as you know, for everyone, and we have got pretty full house tonight, everyone is really keen on the understanding of what some of the studies are that are slowly coming out of National Institute of Health and some of the other funders, understanding some of the research that's going into it. So we do have Dr. John Aucott with us, and his introduction will follow just in a second. So I want to give a couple of accomplishments. You know, PA Lyme incorporated in 2012, and it started with really a handful of individuals, mainly all of us that had Lyme or children of ours that had Lyme. And with that really critical mass nucleus of about 5 or 6 individuals, we have grown to be 20 regions now in the state of Pennsylvania. Last year, we did a medical conference at the Hershey Hotel in conjunction with iLads. It was for medical practitioners. We had about 75 medical doctors, nurses, naturopaths, and the like. Very overwhelmingly a success. We will hold another one in 2025. Last year, we added 3 new regions for PA Lyme, Philly Lyme Support Group. Emily Yost has been running Philly Lyme for well over a decade. And it's through a combination of interests and really wanting to work together to be more efficient. She is now working under the umbrella of PA Lyme. Really, not a whole lot has changed for her, other than we hope we're broadening resources that are available to her. North Lancaster County Lyme Support started last year. Teresa Carruthers out of Ephrata. We're very happy to have Teresa working with us. Chester County Lyme Support as well, with Ann Fulmer as being the regional leader there. So in addition to growing our footprint of regions, which is really important for when we're trying to work with Lyme doctors and trying to get education resources out to high risk groups, that's super important. But also important is what we're wanting to do with starting a virtual Lyme youth support group. This will be started. We have a volunteer, Rachel, and Julia, her mother, I can't think of the last name at the moment, forgive me. And it is Rachel, who is age 23, that is going to be spearheading this group for individuals between the ages of 18 and 25. So coming up, please mark your calendars. February 20th, we're going to be holding a virtual support meeting. A lot of you recognize that pre-COVID, a lot of our regions held monthly meetings. During COVID, we did not have the luxury of being face-to-face. And there's a lot of regions that are still not holding monthly meetings. There's been really kind of an overwhelming request for us to hold some virtual support meetings, and we're going to honor that and start that February 20th. It'll be small group, it'll be open discussion, Q&A, share, learn, contribute, and it will not be recorded. That'll be February 20th. March 19th will be a virtual Lyme impact session. It's going to be on the state of Lyme disease research as well as federal legislation advocacy. We had Nicole Bell, author of What Lurks in the Woods, speak to us a couple of years ago. She has done a lot of research and has put a study together for the Citizens for Lyme Action. We also will have Bonnie Crater, co-founder of Bay Area Lyme, that are talking about federal legislation and how that impacts Pennsylvania. Mark your calendars for April 6th. At the Hershey Lodge, we'll be holding a patients and parents conference. We anticipate probably 100 to 125 attendees. We have 4 speakers, 4 presenters. We will provide a gluten-free lunch. It's a full day Saturday, and it's really a great opportunity to network, to meet with others, to ask questions. We're going to be getting the registration information out in the next 2 or 3 days. If you want to cut your cost, we have an early bird registration until mid-February, which is $50, which is really quite attractive. So at this conference on April 6th from 9 to 5, our keynote speaker is going to be the president of ILADS, Dr. Amy Aucott, and she's going to really be opening with talking about the science and the research, just the evolution of the body of research and the studies that are happening that informs ILADS guidelines and what that means to the Lyme community. So we're pretty excited to have her. We're honored that she's coming. We're also going to have Dr. Nancy O'Hara, recently wrote a book, Pans and Pandas, Neuropsychiatric Lyme, Pediatric Lyme for Children. Dr. Stephen Bach, former past president of ILADS, will be talking about more than just Lyme, the co-infections. We're starting to get data that shows, looking at combination courses of antibiotics, integrative courses, either with herbal or other types of immune boosting protocols, the integrated approach of treatment seems to be the way that individuals that have not benefited a lot in the past from treatment are starting to see some strides of improvement. So he'll be talking about that type of integrated protocol. And we have Dr. Chris Turnpaul, and he's going to be looking at immune modulation and really looking from a functional medicine perspective, looking at what can be done to really give yourself an edge as you're working on post-treatment Lyme disease syndrome, chronic Lyme, and the other co-infections. So as you can see, that's going to be a full day. We certainly hope that you'll join us. We'll be getting emails and information out on Facebook. The other thing that's really exciting, May is Lyme Awareness Month nationally. we are going to be getting a Pennsylvania state government resolution that May is Lyme Awareness Month in Pennsylvania. In conjunction with doing that, Senator Michelle Brooks will be working on writing the resolution. She is the author of Senate Bill 100 that will hopefully be making its way to the full Senate for a vote. And with her effort and her support, we're looking at really launching May as being meaningful for awareness and education in Pennsylvania. The Quiet Epidemic is an independent film. Some of you may have seen it. We're going to be rolling it out and showing it Pittsburgh, Ephrata, Harrisburg, Delaware County, Lehigh Valley, and probably 2 or 3 other regions. What we have done is we have requested financial assistance so that we can do this without charging the public. So each of those areas will be broadcasting, announcing when we're going to be holding the film. Post-screening will be a panelist of a Lyme literate doctor to answer any questions that you might have. So our request to you, as our advocates for Pennsylvania Lyme, you in the Lyme community, we'd appreciate your support in coming on out and sharing the information with your friends and family as well. So with that, allow me to do a stop share. I'd like to segue into our main topic for this evening. And we have with us Dr. Aucott, who's an associate professor of medicine at Johns Hopkins University of Medicine. He's a director of the Johns Hopkins Lyme Disease Clinical Research Center. So he's a principal investigator for the SLICE studies of Lyme disease, where his research interests center on the pathophysiological diagnosis and treatment of Lyme disease-associated persistent illness. He's an active clinician and educator. He's the program director for the Johns Hopkins Fellowship with the Lyme and tick-borne diseases. So he's the past chair of the U.S. Department of Health and Human Services Tick-Borne Disease Working Group. He's a recent speaker at the National Academies of Sciences and Medicine workshop on research-associated chronic illnesses to examine overlapping clinical and biological factors. We really can't think of anyone that's better positioned to really share with us what's going on in terms of Lyme research and some of the studies, and to share with you his current study and how you can be a part of that. So again, just by way of housekeeping, if you have any questions for Dr. Aucott, please put it in the questions box. We're going to hold them to the end and then ask them. If you're on Facebook live streaming, we will not be able to take any questions through Facebook tonight. So with that, Dr. Aucott, thank you for your patience. Allow me to turn it over to you, and welcome.
Thanks, Eric. It's really great to be here, and it's really amazing to hear all the things you're doing with your group, and it's encouraging to see so much going on and so much help that you're providing. It's an impressive lineup you've got going. So I just want to admire and congratulate what you're doing. I'm going to share my screen now, and you can tell me if that's full screen for you now.
It's full screen.
Okay.
Good.
Super. All right. Well, thanks, everyone. So I'm going to talk about some of the challenges of Lyme disease, some of the research we've done to elucidate those challenges, and then go on to chronic persistence in Lyme disease, some of the future research, and then some of the treatment trials we're doing. Tick-borne diseases are challenging because, as you probably know, the deer tick, Ixodes scapularis, transmit not just Lyme disease, but also Borrelia miyamotoi, Powassan virus, anaplasma, babesia. So one tick can transmit multiple pathogens, and to make life even more complicated, Lone Star ticks can transmit diseases as well. They can transmit a Lyme disease lookalike called STAR-I, that stands for Southern tick-associated rash illness, and also the infamous alpha-gal meat allergy. So lots of ticks, lots of diseases, most infectious, some not, like alpha-gal. And where you live in Pennsylvania, especially on the eastern side of the state, you have Lone Star ticks as well as deer ticks. So we have to really deal with all these potential things. And I'm just saying the stage for what I'm going to be talking about today, it's complicated. There's lots of things going on. It starts, of course, with a tick bite, and ticks aren't like mosquito bites. Ticks stay attached for 3 or 4 days. Tick attachment time is important because a lot's going on when the tick establishes that feeding cavity you see here. That feeding cavity is where the tick is putting proteins in to thin your blood, prevent the immune response. All sorts of things are happening, and the faster you get the tick off, the lower the risk of tick-borne infections. But lots going on with the tick bite, and those proteins that the tick puts into that feeding cavity can cause these small round red lesions. And I point these out because we're going to talk about Lyme disease soon, but this picture here I'm showing is actually a tick bite reaction. That is not Lyme disease. That's your immune response to those tick proteins that were being put in that tick feeding cavity. The difference, though, is that these lesions don't expand like the rash of Lyme disease. That rash of Lyme disease, called erythema migrans, expands about 1 centimeter a day. Tick bite reactions, like I'm showing here, don't expand over time. They usually stay less than the size of a dime, but they can last a long time. They can last weeks or even months sometimes. And sometimes these get confused with the rash of Lyme disease because they are round and they have some central clearing, but that's like the size of the head of an eraser on a pencil, not like the Lyme rash, which is usually 2, 3, 4, 5 inches in size. It's hard to predict what tick bites that were going to go on to cause Lyme disease, and people have estimated anywhere from 2 to 10% of tick bites can then go on to develop the big round red rash of Lyme disease. But that's variable, of course. It depends on what percentage of the ticks are infected with the pathogens in your environment, how long the tick stays attached, and other variables. But it's not trivial. It's a significant number of tick bites cause Lyme disease. And there is the potential for doxycycline prophylaxis immediately after you remove a tick, although that's debated and people talk about whether that's wise or not. But it is something that is available, and you can talk to your physician about whether you take doxycycline, the shorter course or single dose often, for prophylaxis when you just have a tick bite before it develops into Lyme disease. So let's go on to Lyme disease. What I'm going to show you here is kind of the textbook map of Lyme disease. This is what's taught to medical students, doctors. This is what I call kind of Lyme 1A, textbook Lyme disease. And it's a graph of what happens over time on the x-axis, and then the percentage of people on the y-axis. And of course, it starts with that tick bite, and the incubation period is usually 1 to 2 weeks, which time the bacteria are multiplying. They get in the skin and cause this round red rash at the site of the tick bite, plus or minus a flu-like illness. The immune system starts to respond, and even without treatment, the rash goes away. But 10 to 15% of people can develop early neurologic disease in that second phase, usually around 6 weeks later. And again, if that's not recognized, then some people get carditis in that secondary phase. And then the third phase is Lyme arthritis, which typically occurs, it's actually up to 6 to 12 months after the tick bite. So this is what's called third stage or late Lyme disease. So this is the textbook manifestations. And what I'm going to do today is, kind of approach this slightly differently than I have in the past, because I think it's becoming more and more obvious that the textbook manifestations are true and the core of what happens. But as I always tell patients, you may not have read the textbook, so you didn't do it this way. And a lot of things don't happen the way the textbook says it should. For instance, the skin lesions never look like this classic Target department store with a red, white, red ring within a ring. That's actually the minority of the lesions. We published this a couple of years ago. This is actually what they look like. You can see the classic lesions, but look at these other ones. These are all Lyme disease. So the first way the textbook isn't quite right is it's usually not a target lesion. About 20% are target lesions, but all these other variations are very common, even ones with central blisters in the middle. So first misnomer is that the textbook ring within a ring is the way Lyme disease always appears. The lesions can occur anywhere. They can be in places that are very hard to see, like behind your knee or in your back. And sometimes people don't see them. They may be there, but they can't see them, or they may not be there visibly at all. In dark-skinned people and Black patients, the lesions may be very difficult to see. This is a patient report we published where the patient had this lesion at the time they were seen, but no one recognizes it as Lyme disease because it's hard to see in somebody with darkly pigmented skin. So that's the other caution, is the lesions may be hard to see in people of color. And sometimes the person doesn't have a lesion. We just published this recently last year that shows what symptoms of Lyme disease can occur without a rash at all. These were patients in our SLICE study that eventually developed a rash, but at their first doctor's visit didn't have a rash. And many of them just had fatigue or achiness or headache or fever, chills, shakes, sweats, and these occurred before the rash appeared. And so these people were seen typically and told they didn't have Lyme disease because they didn't have the rash. But the misnomer is you can have these symptoms days or even weeks before the rash appears, and sometimes the rash doesn't appear, and this is a classic symptom of Lyme disease. So you don't always have the rash, especially in the first few days of the infection. So if you don't treat that early phase, if you miss it because you don't recognize the lesion or the person doesn't have the rash, then the bacteria go into the bloodstream. Really more than half the time, the bacteria will enter the bloodstream and go to other areas of the body. That can includes other areas of the skin. You see this young man with multiple skin lesions. That's from the spread of the bacteria from the tick bite skin to other areas of the skin through the bloodstream. It can go to the neurologic system, and you can see this young man has a Bell's palsy or seventh nerve palsy from spread of the bacteria to the facial nerve. It can go to other nerves, and it can go to the heart. So second phase Lyme disease can be pretty darn serious because it can involve crucial organs like the heart and the neurologic system. When it goes to other areas of the skin, the lesions don't look classic at all. Now we have big lesions that are starting to merge together. They don't always have complete circles. They can be multiple lesions. And so people usually don't identify this second phase of multiple skin lesions. Another chance for lost opportunity of diagnosis. One of my most concerning and important things that we study here, as well as when the bacteria spreads to the heart. This was highlighted in a MMWR CDC report back in 2013 when 3 people died actually of Lyme carditis. This is the Lyme bacteria in the heart muscle. And what I think is really telling about this, again, showing the difference between the real world and the textbook notion of Lyme disease, these people that died of carditis actually had no rash on their autopsy. And when they interviewed the next of kin of these patients, none of them really described carditis. They had a non-specific illness with malaise and achiness in the 2 weeks before they died. So this kind of challenges the notion that this textbook manifestations that I showed you always occur, and really leads to, I think, what I call upper division, Lyme 101, more an advanced understanding of Lyme disease, is that the patients don't always read the textbook. They don't always have these classic manifestations. Sometimes they just have symptoms like fatigue and malaise and the symptoms I showed you in those carditis cases without the textbook objective manifestations of things you can see like facial palsy. And that's what I call persistent symptoms. Without textbook findings, people sometimes are calling this persistent Lyme disease these days. It's got a lot of names. And then the second thing that I do a lot of research work in, and it's our area of study, is what happens if you treat these early phases either unintentionally because you don't know what they are and you treat with antibiotics just non-specifically, or you treat but the person doesn't get better. and that's what's called post-treatment Lyme disease in the research world. Patients would commonly call this chronic Lyme disease. It doesn't matter to me what we call it. It's the phenomenon of some people actually do get treated with antibiotics, but they don't get better. And that's really important to this audience and me, because these are people that, you know, are still sick after treatment of their Lyme disease. And, you know, this is my puzzle picture that goes with the title of this talk. You know, what I'm trying to lay the groundwork for is we don't know everything we need to know about Lyme disease. It's a puzzle that still has a lot of missing pieces, that we don't really have the complete puzzle together because we have this incomplete picture, and we have these questions that have not been answered. How to make an early diagnosis when the rash is absent? How often is the nervous system involved? Can the bacteria Borrelia burgdorferi persist after antibiotic treatment? How is the immune system impacted? What's the role of co-infections? Very importantly, how do you measure cure? And the holy grail is, why don't some people get better after treatment? And how do you predict who those people are going to be so you can intervene early and try to help them? So this is a puzzle we're trying to figure out at the Hopkins Lyme Clinical Research Center. We understand that this puts people into a quandary because we haven't answered all these questions yet. The puzzle's still incomplete. And I just want to acknowledge that this is a huge problem. Allison Redman, who's one of our young faculty here at Hopkins, has been studying the problem of what happens when you have uncertainty and patients' narratives, their stories are contested. This has recently been called, you know, like medical gaslighting is a term you hear. At the time she wrote this, that term wasn't being used much, and she termed it living in limbo. It's that state of being where you know there's something wrong, but the doctors don't know exactly what's going on and they don't understand it, and so they aren't able to you know, prescribe a specific diagnosis or treatment. And what Allison found in these patients these are basically patients with chronic Lyme disease, she described that they were really living in limbo. They had medical uncertainty, their physicians had medical uncertainty, and so the kind of care and responsibility shifted sometimes from the doctors to the patients because the doctors were uncertain about what to do. And so they ended up in this limbo state where they had medically unexplained syndromes, and that this was almost worse than having the disease itself because it left them, you know, isolated and in the prone to these social sequelae that come with having a contested illness. So we acknowledge that this is a huge problem and that it's something we have to solve so that people don't have someday these contested illnesses, that people understand and know how to diagnose the illnesses like chronic Lyme disease so that physicians can understand better how to help their patients. So there's a lot of uncertainty with Lyme disease because the diagnostic tests don't work well. So I'm going to spend a little time on diagnostic testing because it's a huge problem, because testing for Lyme disease especially doesn't work that well. So if you have a tick-borne disease, if you're lucky, you have the classic Lyme lesion, and now you also know what the non-classic Lyme lesions look like. And if you have one of those, you actually do not need any blood testing. That's the diagnosis, and you get treated, or you should get treated. And that's the easiest scenario. Unfortunately, again, not everyone has the classic Lyme disease. People may just have fever and malaise and achiness and look like they have the flu. This person actually had COVID, but it looked a lot like Lyme disease because he didn't have a rash. It had the typical symptoms of fever, chills, and headaches. And typically Lyme disease doesn't have cold-like symptoms. But during COVID, we still saw a lot of misdiagnosis of Lyme disease as COVID, because without the rash, you have to go down this arm of the diagnostic tree, which is no rash. Then you have to rely on blood tests. And again, the blood tests for early Lyme disease don't work very well. You know, in the ideal world, diagnostic testing would be based on pathology, like if you get a biopsy and you see the organism, but that doesn't work for Lyme disease. A, people don't get biopsies, and B, you can see there's one organism in this whole biopsy. This bacteria is very hard to see, and pathology of tissue is not really useful or done often to diagnose Lyme disease. So right away, we're missing the gold standard for diagnosis. We would love things that infectious disease doctors like myself love, like culture or direct tests like PCR tests or antigen detection tests. But those honestly are not widely available either and are still in the investigational phase. We're really right now still relying on what are called indirect tests or antibody-based tests. And these are the least reliable evidence for an infection because they're not the actual infection itself. They're the antibodies made by your immune system. So there's a lot of limitations of these indirect antibody tests. They really only work after 3 to 4 weeks, not in the first couple weeks. There's a lot of false negatives in the first phase of Lyme disease. Only 40% of people will be positive on an antibody-based test in the first couple weeks of infection. They're not useful for monitoring therapy, so they don't act as a test of cure. And after treatment of Lyme disease, the test results are unpredictable. They may become negative, they may be positive. That's very unpredictable. Put it this way, they're not a good test, and everyone knows we need a better test for Lyme disease. Yeah. Moving on here. So unfortunately, the interpretation of these antibody tests, the so-called two-tier testing for Lyme disease, is very confusing and complicated. This is the algorithm. And the key thing I want to point out here is the algorithm for a positive test is dependent on how long you've been sick. If you're sick less than 30 days, you use an IgM and an IgG test on antibodies. If you're sick for more than 30 days, only the IgG. That's very complicated. We don't always know how long the person's been sick. And so this two-tier testing with this 30-day rule is incredibly complicated. Even more complicated is the second tier, the confirmatory tier, requires what's called a Western blot. And to be positive on these blots, the IgM has to have 2 out of 3 bands, the IgG 5 out of 10. This was designed for surveillance specificity. It's very hard to apply. The rules are different for IgM than IgG. And needless to say, this is another point of confusion for antibody testing. And so what's happened in the last year is the second tier, these Western blots, have actually been replaced by a second ELISA. And so you'll see on tests now for Lyme disease that you have an ELISA first, and then if it's positive, the second tier is a second ELISA. And so the Western blots you'll be seeing fewer and fewer of, but this is still not a great test because it still has this 30-day rule for the IgM, IgG. And again, the antibodies aren't there in the first 2 weeks of infection. And so you see that in this plot of, the sensitivity of two-tier testing for erythema migrans, it's less than 50%. In other words, sensitivity of 40% means with the rash of acute Lyme disease, you'd be better off flipping a coin because at least a flip of a coin would give you 50% sensitivity. This is only 40%. Now, the dogma is with, classic Lyme disease, if you wait till there's secondary phase disease with neurologic involvement, that the sensitivity goes up. And it's even better with arthritis. But again, this is in textbook Lyme disease. Many of the patients I see have actually been treated in the early phase. And so what you're really measuring is a convalescent titer of the antibodies after treatment of erythema migrans. And again, the two-tier testing in that situation is highly variable and again, not very good. So when you hear that the tests work for late Lyme disease, in textbook late Lyme disease, they get better and really good in arthritis, but most people actually, you're looking at a convalescent titer after partial treatment or treatment of Lyme disease. So bottom line, antibody tests don't work that well. What are we doing about it? So the Stephen and Alexander Cohen Foundation have come into a public-private partnership with Health and Human Services. They've established this LymeX Diagnostic Prize with a competition actually to come up with a better diagnostic test for Lyme disease. And this is really a huge initiative funded by the Cohen Foundation in cooperation with Health and Human Services. And there's competitors now that are trying to come up with a better diagnostic test, and they're competing for prize money to accelerate and motivate rapid development of new diagnostic tests. So we're working with Tufts on one of their tests to develop radically different approach to antibodies to different things that may be more sensitive. We're working with George Mason University that are working on a urine antigen test, which is actually available in a non-FDA approved form right now, but they're working on getting an FDA approved test. And we're working with other people that are looking at PCR technology, looking at markers of gene regulation and gene expression. So there's actually, the good news is there's a lot going on in the development of new diagnostic tests. And I'll be bold enough to predict that there will be a better Lyme diagnostic test in the next few years for Lyme disease that gets around these radical shortcomings of the currently available antibody tests. So I was asked to talk about treatment and chronic Lyme disease, which I'm going to transition to now. Treatment of Lyme disease, and now I'm talking about the initial treatment of Lyme disease, is with antibiotics, typically oral antibiotics. I'll just point out that many commonly used antibiotics in medicine, like Cipro and Z-Pax and Keflex, actually do not treat Lyme disease. So this is another place we see a lot of problems. We see people treated with antibiotics like Cipro or Keflex for Lyme disease, and this will not cure your Lyme disease. The treatment is doxycycline or amoxicillin. And if you get treated with one of these other antibiotics, you're very likely to go on to develop chronic Lyme disease if that's not recognized and remedied quickly. Some people require IV antibiotics. That's typically for people with neurologic disease or difficult to treat Lyme arthritis. And so we actually do a fair amount of intravenous antibiotic use for people with documented neurologic disease or recalcitrant Lyme arthritis. But this is for the initial therapy of Lyme disease. We're not talking about chronic Lyme disease. This is the initial therapy of Lyme disease at the time of diagnosis. So the prognosis with that treatment, when you treat textbook manifestations of Lyme disease, is pretty good. It's not perfect though. And so we became very interested and concerned about the subset of people that get treated with antibiotics initially, but still have chronic or recurrent symptoms. It was been known a long time that people with late Lyme arthritis, that 10% of those people are not cured with antibiotics, even IV antibiotics, and develop a persistent inflammatory arthritis that's currently thought to be autoimmune in nature. So 10% of people, these are people that even got IV antibiotics, have persistent illness and arthritis even after treatment. And then what we became very interested in are the people that develop persistent symptoms after treatment of earlier stages, first or second stage. And these are people that develop the persistent symptoms that you would know as chronic Lyme disease, or in the research world, we call them post-treatment Lyme disease. It's the same thing. We just finished a large study with over 300 patients last year that we think really proved once and for all that this is real. Now you may be saying, well, come on, we know it's real. And I knew it was real, but honestly, the literature didn't recognize this as real and significant until last year when we published our big study, and there was a second study published. I think the debate should be over now. Post-treatment Lyme syndrome / chronic Lyme disease is real. People get confused about what to call it, but the bottom line is it occurs. In our study, it was 14% of people after treatment of early Lyme disease, which was really the ideal circumstance. We were treating people at the very early stage, and still 14% of people develop persistent symptoms. And so we think this really should end the debate about whether this is real or not. We identified risk factors for having post-treatment Lyme disease, which included female sex, and that's similar to these other related illnesses that look a lot like this, like long COVID and chronic fatigue syndrome. So whether you call this chronic Lyme disease or you call it post-treatment Lyme disease, it's the same thing. In the research world, we call it post-treatment Lyme disease because we want to use a research definition for people that had documented Lyme disease, were treated, co-infections were treated, and yet they still had persistent symptoms of fatigue, cognitive complaints, and pain. And they're serious. They impact people's lives and function. Other causes have been excluded. Interestingly, a positive Lyme test is not part of the case definition of post-treatment Lyme disease, because again, I told you how terrible the Lyme serology tests are. Really, there aren't good tests for chronic Lyme disease. And the symptoms we've documented of what that looks like. It looks like fatigue, joint pain, memory loss, so-called brain fog. And in our post-treatment Lyme patients, these are much more significant than in the controls. And yet these are long COVID patients. Compare the long COVID patients to our long Lyme patients, post-treatment Lyme. They're very similar between post-treatment Lyme and long COVID, and they're much worse than the baseline rates of these symptoms in people that haven't had one of these two infections. So these are the classic symptoms: fatigue, brain fog, and pain. Post-treatment Lyme, chronic Lyme looks a lot like long COVID. And so how do you establish the diagnosis? It's actually based on the physician's evaluation of the patient. There is no one test that establishes the diagnosis of chronic Lyme disease. I tell, when I'm teaching people how to identify chronic Lyme disease, is they have to find the beginning of the story, when the patient became ill, because that's how you understand whether what started their chronic illness was Lyme disease. These days, it's really even more important, because somebody could have had COVID that started their chronic illness, and then they don't have chronic Lyme disease, they have long COVID. So it's really crucial to find what I call chapter one, and that you're kind of being Sherlock Holmes, finding the best diagnosis that fits the beginning of their story, and showing that it was Lyme disease. You have to exclude other things because, again, COVID can cause this. I made all sorts of diagnoses because the symptoms like fatigue have a lot of different causes. So you need a doctor that does a full evaluation and excludes other serious illnesses that could be causing the fatigue and pain and brain fog. But those physicians shouldn't be fooled by comorbidities that aren't the cause of the illness. But sometimes people are told, well, all your symptoms are due to anxiety or depression or sleep apnea, and that can be a trap, because those things are so common in the general population that they usually are not the cause of the person's new symptoms that just came on after a tick bite, for instance. But the blood tests are basically normal. And so what you end up with after you've established a diagnosis of chronic Lyme disease is actually a pretty heterogeneous population. This is my slide for heterogeneous. In other words, the population of people with chronic Lyme disease, there's a lot of different things going on there after you've established a diagnosis. So I'm going to give you our paradigm at the Lyme Center of how we try to create subgroups that we think are critical for basing the treatment of chronic Lyme disease. So we think that this is heterogeneous and that there's multiple potential factors. This is a Venn diagram of 3 Venns. The first has to do with microbial mechanisms. And one hypothesis is that post-treatment Lyme disease is because there's persistent Borrelia burgdorferi pieces or fragments. They may not be alive, or they may be alive, that there could be persistent infection, or that there's other tick-borne or coexisting infections, or that there's microbiome alterations. These microbial mechanisms are Venn diagram piece 1. The second piece is that the infection part is mostly over or is over, but that immune dysregulation and immune causes are now involved, and these can include chronic inflammation from the infection, or infection-triggered autoimmune responses, or metabolism alterations. So these are kind of immune dysfunction, and we're doing a lot of research at Johns Hopkins looking at infection-triggered autoimmune responses. This is kind of the paradigm of a lot of autoimmune illnesses can be triggered by infections like rheumatoid arthritis and rheumatic heart disease, where an infection starts the illness, but then triggers an abnormal immune response. And then the third piece, which we're also very interested in, have to do with alterations in neural networks. This has to do with the impact of the initial infection on your neuroimmune axes, and the impact of inflammation on the central nervous system, specifically glial cell activity, and how cytokines from the inflammation can trigger these CNS abnormal neural behaviors that then cause brain fog and fatigue. We're particularly interested in dysautonomia, which I'm going to tell you more about, because this is something that's become very obvious, is probably part of some people's illness with chronic Lyme disease, has to do with the autonomic nervous system, so-called dysautonomia, or you may have heard of POTS, which is part of dysautonomia. And of course, these are all regulated by the person's genetic background, by their illness experience, and by factors related to the microbial strains. So if you look at this, this is what we do at Hopkins. We've really factored in all these things. This is a darn complicated Venn diagram, right? There's a lot of stuff to look at going on here. And that's why we think that it's inevitable that no two patients are exactly alike. So when people ask me, well, how do you treat chronic Lyme disease, Dr. Aucott, it says, well, it depends on the patient, because I'm really trying to factor all these things in. And some person might have two of the things in play or three of the things. Every patient, honestly, is a little different. And so we don't have a pat way to treat chronic Lyme disease. We try to model this about what subgroup the patient best fits in, and that guides our approach and therapy. So when we talk about antimicrobial treatment, our initial assessment spends a lot of times looking at the adequacy of the initial antibiotic treatment, make sure they got treated with the right thing. We try to make sure the person hasn't gotten reinfected, because you can get Lyme disease more than once. We're very focused on neurologic disease at Hopkins. And I would say that that's one of our strengths. We really have a deep base in neurologic evaluation. We work with the neurology department at Johns Hopkins. We do a lot of neurologic testing, nerve conduction studies, lumbar punctures, CNS MRI. We're very attuned to neurologic diagnoses, because that may require retreatment. We also do a lot of work in refractory Lyme arthritis, and have special expertise in that as well. So one of the themes at Hopkins is we have special expertise in some of these deeper, more subgroups of Lyme disease. We also assess whether the person could have a co-transmitted co-infection. We're actually going to be doing research work on concurrent infections such as Epstein-Barr virus. We've just learned that we'll likely get a grant to fund work with Stanford University looking at Epstein-Barr virus and its role potentially in perpetuating, the disease in chronic Lyme disease. And then you probably all know that there's a lot of animal model work. We don't do that at Hopkins, but Monica Embers, who's a colleague and a co-investigator with me, Monica Embers does a lot of work on antimicrobial and combination antibiotics. This currently is in animal models and Reese macaque monkeys and mouse models. And so this is an area of research that's in mouse and animal models right now, but obviously is a huge area of research that's super important. The second Venn diagram circle had to do with autoimmune diseases, and we have a special program at Hopkins looking at musculoskeletal ultrasound, looking at inflammation on ultrasound in the joint and periarticular tissues. This is a very specialized technology that's not available in many places, where we can tell if somebody has a painful knee. More than just looking at the knee or feeling the knee, we can do in-office ultrasound to document that the person has inflammation. This is super important, because if people have inflammatory changes in their joints or periarticular tissue, that puts them into a subgroup that's very different and may require very specialized treatments for that inflammation, more than just Advil or Aleve, more advanced therapies for joint inflammation. But you don't know that just by looking at the joint. You need these specialized tests like musculoskeletal ultrasound. And then the third circle has to do with neurologic and central nervous system dysregulation. And this has become very apparent. Actually, we've learned a lot from long COVID and chronic fatigue syndrome, where they've noticed that the autonomic nervous system, which here is represented by the vagus nerve, goes to all of your body. And that if your autonomic nervous system is dysregulated, it causes problems called dysautonomia. And part of that has to do with reduced blood flow to your brain, because your autonomic nervous system controls your heart, beats, your heart pumping. And if this dysregulated, you don't get enough blood to your brain. And if you don't get enough blood to your brain, it's no wonder you could have brain fog or fatigue or memory loss. And this has actually been documented now in long COVID. It's been known for a long time in chronic fatigue syndrome. And we're just now starting to look at this in chronic Lyme disease. And we have a new young faculty member that's starting a dysautonomia clinic for chronic Lyme disease to look at these problems with the autonomic nervous system, because those have different treatments than the other parts of the Venn diagram. And this is a figure that shows how blood flow to the brain is reduced. This is percent reduction in blood flow. This is in people with chronic fatigue syndrome or with POTS, and how the blood flow is diminished compared to healthy controls. So if you have a quarter of your blood flow reduction to your brain in chronic fatigue syndrome or POTS, that may be a good reason why people are tired and have brain fog. We're starting to do the same things in Lyme disease, and we're looking at people that meet the criteria for POTS. In our first survey of our chronic Lyme patients, 5% of the people met the criteria for POTS. We also are doing a symptom survey now called the Compass 31, which looks at symptoms of dysautonomia, and we found that in the green bar for post-treatment Lyme, that a high percentage of the people have symptoms suggestive of orthostatic tolerance or POTS on the survey, and that this identifies people with our chronic Lyme that may benefit from treatment of POTS. Interestingly, there's other aspects of autonomic dysfunction besides POTS and orthostatic intolerance that relate to other things that people have long been confused by. These are symptoms that physicians usually don't have a good feel for what's going on. Vasomotor dysautonomia has to do with hot and cold sensitivity and color changes in the extremities, a common symptom we hear about. Gastrointestinal has to do with irritable bowel-like symptoms in people with chronic Lyme that people have attributed in the past just to irritable bowel syndrome, but we're finding it actually may be present as part of this dysautonomia syndrome, sometimes urinary symptoms, sometimes eye symptoms. So dysautonomia can affect lots of different organ systems, not just the POTS and pulse and blood pressure. And we think this is a huge area that needs to be understood better, because it's actually treatable in many different ways and can't be treated if you can't identify it. So what are we doing to treat Lyme disease investigationally at Hopkins? I wanted to spend just a quick moment to tell you a little bit about the Lyme Disease Clinical Trials Network. This is a network of institutions that's forming around the country, sponsored by the Stephen and Alexander Cohen Foundation. The central organizing institution is Columbia with Brian Fallon, and we're one of the main collaborators in this new clinical trials network. We're adding institutions all the time. University of California at San Francisco is just coming on. Children's National in Washington is a member. And these institutions are trying to set up clinical trials to actually come up with documented therapies that may help our patients, that can actually have trials that document that they're effective, and with those trials then can be potentially brought into mainstream medicine. So as part of this clinical trials network, we started a treatment trial looking at a pilot study for tetracycline. This tetracycline trial is based on observations by Lyme physicians, especially Dr. Sam Donta, that found that tetracycline, when used for longer periods of time, may be beneficial for treating the symptoms of post-treatment Lyme disease. So we have approval to study tetracycline administered for 3 months as compared to what's currently FDA approved, which is more like 3 weeks. So this 3-month therapy has been approved for study. This is a double-blinded crossover study where patients get either tetracycline or placebo for 3 months and then cross over and receive whatever they didn't get in the first 3 months, they get the second 3 months. So if they get placebo, initially they get tetracycline in the second half, the second 3 months, and it's FDA sanctioned study of the long use of tetracycline. And this is the contact information if you want to learn about it more, or you can always go to our main website at hopkinslyme.org. So that's a really important study, we think, not because it's completely novel to use antibiotics for longer periods of time, but because it's the first study that's really ever looked at it in an organized, rigorous way so that we can look to getting these types of therapies actually approved for general use among general physicians. The second study we're involved in, which is a little further out on the edge, is we actually have a Hopkins approved study for looking at psilocybin therapy for the treatment of post-treatment Lyme disease, and that's the contact information for that. And this study has to do with changing those neural networks we were talking about, where the neural network alterations are maybe amenable to kind of rewiring using psilocybin. And psilocybin has obviously a dramatic impact on neural networks and connections, and also as an anti-inflammatory as well. So we have a pilot study that's also looking to enroll people for psilocybin therapy. This is not placebo controlled. Everyone in the study gets psilocybin and they know they're getting it. It's not a blinded study. So these are examples of research that's going on at Hopkins to look at better treatments that can be brought into the mainstream of medicine potentially. Well, we're trying to put this puzzle together and figure out all the nuances of what's causing chronic Lyme disease. Because obviously we want to put the whole puzzle together. We want to figure out exactly what causes all these hard to explain problems and how to treat them specifically. And I'm confident someday we will have the puzzle all together, because there's a lot of research going on. I've described some of it in this short talk, but there's other things we're doing, and I can talk about those in the question and answer period as well. There's a lot going on at Hopkins. We're a big institution, and we work in the Department of Medicine with people in neurology, in psychology. We work with people in the School of Public Health. We work with people in the Applied Physics Lab looking at AI applications for diagnosis. There's a lot of pretty cool stuff going on, and I appreciate the chance to answer any of your questions about what we're doing and about anything. And I appreciate the chance to share this with you.
Very informative. Clearly, a lot of time was put into the presentation and just the body of knowledge. And thank you for that. We have a lot of questions, so allow me to start just with a couple right here. In your slide deck, you said that 14% of patients in your SLICE study that went on to have post-treatment Lyme disease, that it was validated, that 14%, but that study was what you might consider textbook, best case, early diagnosis, early treatment. What's your thought on the practical implications of a study like that in a real world where people don't get early diagnosis, they don't get early testing? Wouldn't the percentage be, significantly higher?
We think so. So you're getting to the really crucial question about generalizability. And this is an issue with all studies, right? When people do studies on heart attacks, they study the best patients that they can get into studies that have the clearest diagnosis. They're never the messy world of real medicine. So I agree completely with the question. It's highly likely that with misdiagnosis or delayed diagnosis, which we didn't study, right? Because it's hard to study misdiagnosis, right? How do you enroll people that are misdiagnosed at the time of misdiagnosis, right? Much harder to do. So we think it would be much higher. Some of the studies looking at neurologic Lyme disease, which is a little later stage, suggest that the rates may be higher, maybe 30% or even higher. So I totally agree with that question. But why our study was so important is before that study, people didn't even believe that there was any problem. And now we can say there's a problem, because even in ideally diagnosed people, there's a problem. So it's going to be worse in people with delayed diagnosis. I totally agree. And so that's just a call to action, right? A, we need to minimize misdiagnosis, and B, we need to understand that it's likely a bigger problem than we understand from that 14% number, because the real world's always messier than the research world, that's for sure.
The new diagnostic tests, is there any movement in having them be able to track response to treatment?
That's the holy grail, right? So I always use the example, if you had prostate cancer and your PSA was 20 and you had your prostate taken out by your surgeon and you go to your first follow-up visit, your follow-up PSA better be 0, right? Or they didn't get all the cancer. We don't have a test like that for Lyme disease. It's the holy grail. We are working on those, but they're darn hard because, as I pointed out in one of those earlier slides, we still don't have a way to culture the organism or even do reliable sensitive PCR testing. We're working on it. The problem has to do with the limits of detection. There's so few bacteria in the bloodstream with Lyme disease that you literally have to be able to identify a single organism. And that limit of detection is a technologic challenge. You know, when you're trying to diagnose an infection like a urinary tract infection or sepsis, you have hundreds of thousands of organisms. With Lyme disease, you have 1 or 2. And so it's really a technological challenge. I think we're getting there. There are a couple people we're working with that have advanced sensitive diagnostics that may have broken the barrier. So that's why I said I'm cautiously optimistic that in the next few years, we will have tests that could be used as a test of cure. Well, there are also ways to look at your host genetic response to infections. It's called epigenetics. It's the science of looking at your DNA as a kind of recorder event of what's happening in your life. And that recorder epigenetic changes can potentially tell you if your infection's gone. That sounds like science fiction, but it actually is a project we're working on, looking at actually DNA changes that can predict who's going to develop chronic Lyme disease. And so you hit a nail on the head. That's honestly the holy grail, and that's our ultimate goal.
Gotcha. It's exciting. You pointed out that persistent inflammatory arthritis is thought to be autoimmune related. Is there a connection between persistent neurological Lyme that could also thought to be autoimmune related?
So that's one of the big scientific debates right now. I'm actually going to be on a panel at the American Academy of Science next month, and there's going to be a panel, and some of the people think that the neurologic long COVID and long Lyme is autoimmune. And as you know, some people think it's from persistent infection, and that's the debate right now. And I didn't have time to show some of the work we're doing, but we're looking at central nervous system imaging using PET imaging that measures glial cell inflammation. And we're able to show that there's definitely inflammation persisting in people with chronic Lyme disease in their glial cells in their brain. But the next question is that being driven by persistent infection, or is it now an autoimmune kind of phenomenon? The debate is split on this panel I'm going to be on. I think some people think it's autoimmune and other people think it could be persistent infection. And it's a work in progress. I'll tell you, long COVID is helping us, though, because there's a lot of research going on in long COVID, and because of the kind of crisis nature of COVID, and a lot of federal money went into research, and we're working with the people in long COVID because we have the same questions. It's the exact same question in long COVID as it is in chronic Lyme. Are the brain fog symptoms being driven by inflammation that's independent of ongoing infection and autoimmune in nature, or is it still some lingering hidden remnants of infection that's driving it? But the COVID people are doing big studies on that as well. So I think that's been a benefit to us because we have similar themes, and that's why we're starting to do these workshops together, because we can share information and share research approaches. And I think it's going to help us in the Lyme world.
That's good. You had mentioned that they're studying Epstein-Barr virus in Lyme disease patients in conjunction with Stanford University. And there are studies that have linked Epstein-Barr with multiple sclerosis. And anecdotally, my experience in talking with patients that come to our support groups, it seems like an unusually high percentage of them have also tested positive for Epstein-Barr. Is there a correlation, do you believe, perhaps Epstein-Barr as a cofactor in multiple sclerosis?
So, it's really tricky because those tests for Epstein-Barr are usually antibody tests. And so it gets back to my dilemma about, do antibodies mean the same thing as actual infection? It's tricky though, because Epstein-Barr virus antibodies are present in like 95% of the US population. So it's more than just the antibody levels. And so the studies we'll be doing with Stanford go beyond the antibody levels and look at actual molecular features of Epstein-Barr virus beyond just the antibody response to the infection. Epstein-Barr virus is present in almost everybody, but in some people, that is the cofactor that leads to chronic problems like multiple sclerosis. So we'll be looking at molecular basis of that. And the group at Stanford we're working with is actually one of the people that published on multiple sclerosis. So that this is their area of expertise. It wouldn't surprise me if it's a cofactor that sets the stage for the development of problems, but it may again be that it triggers autoimmunity. It may not be that the Epstein-Barr virus itself is killing cells or attacking cells. It may be that the Epstein-Barr virus is the cofactor that led to the autoimmunity. We don't know. That's what we'll be investigating.
It's often said that Lyme disease is, the second great imitator, whether it's Parkinson's, chronic fatigue, fibromyalgia, easy for me to say, multiple sclerosis.
Yeah.
The connection and linking Lyme to things like that, specifically multiple sclerosis, is there studies that are trying to build more of a case correlation between Lyme and MS?
I think that's the next frontier. We've focused right now on long COVID because they're so strikingly similar. But MS is another kind of, very similar paradigm where, you have an infection. In that case, the infection may be Epstein-Barr, but maybe other things that leads to one of these chronic illnesses. But that's I think in the future. Right now, I think most of the work's going on with long COVID and Lyme disease.
Next question's challenging because it could be a little political in nature, but it's always on the mind of individuals in the Lyme community that if it's widely recognized that the current Lyme tests are unreliable, why are they the ones that are just widely used by medical doctors when there's better tests out there like IGeneX or MDL or Galaxy, what have you?
So I'll share with the audience that Eric and I had a discussion before the talk about my position on political things. And I don't know if you remember, Eric, what I said I was. So I'm the Switzerland of these controversies because I don't know the answer, and I'm hopefully humble enough to know when I don't know something. You're right. There's a lot of controversies about what tests to use. I don't pick sides in the political debate. I'm just trying to figure out better answers. But you're right. There are different tests. The problem is, and this gets very complicated, those tests that you mentioned are often not FDA approved. And so it gets complicated because, the standard tests that docs tend to use are FDA approved tests, like the ones run by, LabCorp and Quest and the big commercial labs. But there are what are called laboratory developed tests, like Galaxy's a good example, a really good lab that has laboratory developed tests that are super sophisticated, but they're not FDA approved. And so that becomes, an issue. And that's not even a political issue. It's more a structural, issue. So it's complicated. I don't really have an answer to you other than to say that we need to do better. So I'm focusing on doing better. People like Galaxy are working really hard. I talk to them quite a bit, so I know what they're doing, and they're doing great work. But, it's tough when you have a test that isn't FDA approved. And, as they're also expensive, right? So, there's a lot of challenges to non-mainstream labs from commercial labs that are covered by insurance and things. There's just a lot of structural impediments out there.
We certainly recognize that, but it seems like the environment is loosening, it's getting more liberal. I think as Lyme disease becomes more prevalent, it's certainly not getting any better, but as it becomes more prevalent, better diagnosis, it almost at some point is going to have to move the bureaucracy in a direction of looking at, ulterior ways of detecting. So
I
we
just want
always
to
talk
say,
about the tipping
yeah.
point.
Well, and I just want to say, that's what I showed you that LymeX Cohen sponsored competition. That's the whole point of that competition. That's a multi-million-dollar competition to accelerate the development of FDA approved tests, and not just as typical. So people are really working hard on this. I mean, we're advisors to that program, and there were 10 companies working on that. So there are people really working around the clock, and that whole competition is to get a test that's FDA approved, so that it would be an advancement, but it would also be approved so that it could be, covered by insurance and things like that. So people are really working hard on this. And that's what that whole LymeX competition is about that I was telling you about.
And thank heavens, private foundation money has come into play, because if we were solely reliant on federal or state, it'd be another decade. So thank heavens that that's happening.
It's been transformative. I mean, a lot of the innovations and research have been funded by private foundations.
Is there, to any degree that you're aware of, a correlation between the length of time somebody's untreated for chronic Lyme to the length of time it takes for treatment to get better?
I'm not sure that's on a individual basis always going to be true. I bet you if you did it as a population and you averaged a bunch of people, that's a reasonable hypothesis, but I'm not sure it's true on a case by, that's always a trap of extrapolating from a population to when I look at one patient in front of me to make that statement. And that, I don't think it's always true on a case by case basis. I think some people were just have a subgroup that responds better to the treatment than other people, because that Venn diagram I showed you, there's so many variables involved, their genetic makeup, the type of Borrelia they were infected with. I'm not sure that's always true. I mean, we tend to think that people that have been sick less than a couple of years tend to respond faster. I'll say that. I've had that discussion with other Lyme researchers that, the people, definitely somebody who's been sick for 2 years probably has a better response than somebody who's been sick 10 years, for instance. But on a case-by-case basis, that doesn't always hold up.
What's your opinion on length of time of treatment?
Well, go ahead, sorry.
I don't know how common it is, but I see it. People will get better and then they'll stop treatment and then they'll relapse. And there are those that will just keep treating until the test results are no longer positive. So, just length of treatment, seeing that correlation to improvement. Do you notice that?
So I'll start with the second half of that. I caution people about using the test becoming negative as the duration of treatment. That's just, in my opinion, that's not good, because the test isn't measuring infection. It's measuring your immune response. And so to treat until the test becomes negative doesn't make any sense to me. In fact, you could argue the other way, that it's better if your test became positive, because that shows your immune system's working better. So I never use the test as the outcome or determine the duration. Now, the first half of this question, I totally agree with. Some people, relapse when they stop the therapy and then get better when they go back on it. And that definitely is true. And it gets to the issue, and that's why we're doing the tetracycline study. We're trying to show or ask the question is it safe, and is it better to treat people longer in this case, 3 months compared to shorter, which, the FDA approved duration of therapy is like 3 weeks. So we're asking that question, but based on your observation, you just said some people seem to do better when you treat them longer. Now, the issue with tetracycline is an interesting antibiotic. It's also an anti-inflammatory. It turns out tetracycline, like minocycline and doxycycline, are antibiotics, but they're also anti-inflammatories. So part of that waxing and waning may actually have to do with its anti-inflammatory effect. Minocycline has been shown to improve the outcome of multiple sclerosis and stroke even, which, stroke you wouldn't think had anything to do with infections, but it's probably because of its anti-inflammatory effect. I don't really know. It doesn't matter to me, honestly. I just want to see if it works. And then if it works, we can try to figure out why. But it gets to your question, 3 months we're hypothesizing is better than 3 weeks, that longer duration may have some benefit.
We got a couple of questions on this that you had mentioned that ocular symptoms caused by Lyme disease. Would those symptoms include, increase in eye pressure, unequal response of pupils of 2 eyes, swelling? So Lyme having that direct correlation to the eye symptomatic problems?
There's 2 ways Lyme has a direct relationship. Well, one's direct and one's indirect. Lyme disease infects nerves, and the nerves are what control your pupillary responses and your movement of your eyes. So there's absolutely, Lyme disease can cause dysfunction of the nerves that control the eye movements. So absolutely, Lyme disease causes double vision in the secondary phase and directly alters eye function and movements. And then the dysautonomia I was mentioning, which is more part of chronic Lyme, again, the autonomic nervous system also controls pupillary function. And so there's 2 ways Lyme disease can impact the eyes. And eye symptoms we find are pretty common, both acutely with infection of the nerves that control eye movements, but also as part of this dysautonomia. And so we, and that's another, specialty we have at Hopkins. We have a huge Wilmer Eye Center, is one of the biggest eye centers in the world. So we do a lot of stuff with them to look at eye dysfunction in people that have had their vision impacted.
Interesting. I don't know how much of an opinion you might have on this, but is there any research looking at herbal tinctures, natural supplements, with them as a complementary adjunct to traditional antibiotic use? That whole integrative approach of a multiple disciplinary treatment protocol, is there much of an appetite to look at that?
So I believe in it. I think it's a viable topic, and I believe in it totally. And I actually recommend my patients do certain aspects of complementary therapies, depending again on their specific situation. So we totally believe in it. It's not my specialty. That's not what I trained to do. So I'm not an authority on whether that works, the science of it, but I totally believe in it. So we refer patients for things like acupuncture and different things like that. And then as long as we don't, we try to guide them into things that are, that are reasonable and not too expensive, but we do that. As far as research, it's not my area. And so that's not an area that we do research in. It's just, we can't do everything. But there was a researcher at Hopkins, Ying Zhang, that did a lot of work on herbal therapies. And Ying has since left the institution, but I think he's still working on that. So there are people working on it. That's just not one of the things that we do here. But for patient care, we refer people for complementary approaches all the time because they complement what we do. On the most basic level, when I give somebody an antibiotic, it's going to mess up their bowel microbiome. So a complementary therapy would be to have them work on, probiotics and things to restore their microbiome of their bowel, because we know that Lyme disease messes that up and antibiotics mess it up even more. So that's a classic example of, I'm not an expert in microbiome or, therapies to restore the microbiome, but I believe in it.
It's interesting you say that. I think that is, over the years, that has really informed my opinion of seeing other individuals get better and just having a broader approach just seems to be a little more traction in getting results and getting better outcomes like that.
Hmm.
Can you talk about the recent NIH funding that was awarded in 2023? The question is trying to get a better understanding of the importance of the R01 NIH funding.
So R01s are incredibly important NIH grants. They're the mainstay of research at large academic institutions like Johns Hopkins or Penn or Hershey or any big academic medical institution. R01s are the driving power for their research. And so it was actually quite exciting that the NIAID, the branch of NIH that does infectious diseases, announced this call for applications for post-treatment Lyme disease last year. And it was really the first time they ever specifically requested applications to specifically look at post-treatment Lyme disease. They've always had a portfolio for Lyme disease in general, but they've never had a specific call for applications for post-treatment Lyme disease. So we were incredibly excited about that because that's what we do, right? And so they awarded 7 grants, and we got 2 at Hopkins actually. One is our work on inflammation and autoantibodies and metabolism changes in chronic Lyme disease, and the other is on central nervous system imaging using functional MRI work that we've been very excited about, that could help make that connection you were talking about with illnesses like multiple sclerosis, looking at imaging of the brain using these advanced techniques called functional MRI and other techniques. So we got a second grant to look at that, and that plays into our expertise in neurologic Lyme disease and our expertise in specialized imaging. So we'll be doing these specialized imaging in people with cognitive problems related to chronic Lyme disease. So we have 2, and 2 of those R01s went to Hopkins actually. So we were really excited about that because those are 5-year grants. So those allow us to really continue this work that we've been doing, funded by philanthropy, frankly. So philanthropy helps us, goes a long way, as you were pointing it out, but it's certainly wonderful to have the NIH coming in to help with this funding as well.
Yeah, agreed. So, just so necessary. In your world, you operate in the academia world, you operate legislatively, you've had influence with the Federal Tick-Borne Disease Working Group, as well as private practice and, working with patients and whatnot. But navigating all of those worlds, one thing that we find as the Lyme community is, we believe this is not getting taught in medical school. We believe doctors aren't getting this, tick-borne disease track. We don't think it's a part of academia. We don't believe it's part of their internship. We believe clearly that needs to change. Do you know if there's any movement to introduce more of this science and understanding into the medical education, curriculum?
So you teed me up for another advertisement I want to give. So
Switzerland?
No, this is different. No, so we actually started a Lyme and tick-borne disease training program at Hopkins 2 years ago. It's a fellowship for people that have completed their internal medicine or family practice medical training. So they have to be licensed doctors that are, have finished their training in medicine or family medicine. We actually started, it's the direct answer to your statement. We started a fellowship 2 years ago for people to get specific training in Lyme and tick-borne diseases so that we can start training the next generation of Lyme and tick-borne disease doctors. So this, you teed me up for a free advertisement. We're looking for applicants actually. So people that have finished internal medicine or family medicine training, they've finished their internship and residency, are eligible to join this fellowship. It's a 2-year program. It's fully funded. They also receive a stipend to attend the Bloomberg School of Public Health. It's a really fantastic fellowship. It's just started, it's the first fellowship of its kind in the United States, specifically to train people to do Lyme and tick-borne diseases. So anybody out there that has know somebody that's an internal medicine or family medicine, resident that's finishing up, they finish in July, that is looking for further training, we are accepting applicants right now for our fellowship.
And that fellowship, is it geographically based? Can it be a doctor in any of the states?
Well, they could have trained anywhere in the United States, but then they come, it's based at Hopkins.
It's on site then, got
I
it.
mean, the fellow that right now, was 5 doors down from me this afternoon. They get trained, and I don't want to say this in the wrong way, but they get trained by some of the best doctors in the world. I mean, we've got in our program, we have Peter Rowe, who's one of the founders of chronic fatigue syndrome research in the United States, is on the faculty here at Hopkins. We have neurologists and rheumatologists. I'm the main preceptor. They really get to work side by side with really an amazing faculty people, and we're all dedicated to this field. They're not just working with people that have a side interest in this. This is a dedicated 2 years where all they do is Lyme and tick-borne diseases.
That's fantastic. I didn't know that Hopkins was doing that. It's so necessary, long overdue, but definitely. And then once you can get it to the point where you've got a good working model, other teaching, institutions can adopt it. So
you read my mind. We'll publish the format and the curriculum and everything.
And that is, we appreciate our relationship with ILADS, and we recognize that, all of us that are in the Lyme community, certainly in Pennsylvania, that had our family doctors, we go back to our doctors that said it wasn't Lyme and it's this, it's that. And so, we will try to educate the doctor so that they understand there is a program at ILADS. They got a preceptorship where they can go and become ILADS trained. So knowing that's there with ILADS, we would want to understand your program a little better. So to whatever little degree we can push people your direction, interns and the like, we would like to be able to do that.
Yeah, and I always tell people everybody has their part to play in this crusade. Everybody's got different roles, right? We all want the same thing, which is to fix this terrible problem and help the patients, but it takes all different types, right? And I have my little niche. I'm an academic based, guy that focuses on that aspect, but it takes all of us to fix this problem.
Agreed. Got a question that I have my answer to it, but I'm curious your answer. So someone that has had Lyme disease and has been treated and what they believe to be treated effectively, can they donate blood? Should they donate blood, not donate blood, be a blood donor?
I don't think there's any restriction on blood donation for people that have had Lyme disease that's been treated, is there? And I don't recommend.
No, I don't think there is. It's probably more of a moral question than anything. Anything you can add to take away to add or subtract from to help us make a higher, better moral decision?
I think if somebody's been treated and they're asymptomatic and it's been more than they've been well for months and are back to their normal health, I don't see why they shouldn't donate blood. The bigger problem is actually Babesia. That's right. More of a problem than Lyme disease, because you can have Babesia and be pretty asymptomatic. So actually and I think they're starting to screen blood in New Jersey, but maybe also Pennsylvania soon for Babesia.
Maryland is the state. This is going back a couple of years, but Maryland, I never understood, never realized it, that the Red Cross really operates in a state-by-state jurisdiction. And the Red Cross in Maryland, my understanding was they screened for Babesia. When we contacted the Red Cross in Pennsylvania, and again, this is 5-6 years ago, they did not. And so I had Babesia, and I was told I probably should not be a donor for that reason.
Yeah, I think New Jersey is starting to, and I bet you Pennsylvania is talking about it at least, because it's a growing recognition of the importance. And so I think that's the more ethical, moral question is Babesia, not Lyme disease.
Got it. This one's kind of out in left field, but sometimes it's the left field questions that 5 years from now will be the norm. Do you have any opinion, either background or an understanding of the efficacy of bee venom therapy?
only anecdotal. I've had maybe one or two patients that did it and reported to me that they thought it helped, but that's not a large, series in my personal experience, and it's also not, kind of research based. So I can't recommend it out of a position of knowledge, but I have had a couple of patients that have done it.
Gotcha. We try to stay pretty true to the time that we advertise this for. I will say we had well over 70 people that attended. This is probably one of the higher attended presentations we've had. And our real benefit is for those of you that are listening, we do put this out. The recording will be on the website probably in about a week or two. So allow me to hit probably a couple other last questions just in closing. You talked about dysautonomia problems as it related to long COVID. Can you overlay that on top of Lyme? Are you seeing the same similarities?
Yeah, we are. We just opened a dysautonomia clinic, and we're doing what are called tilt table tests and transcranial Doppler for blood flow. And we're seeing maybe not as high a percentage as long COVID, but it's very significant. And so we screen all people now for dysautonomia and send them for tilt table testing, because if they have that, there's very specific therapies that can help those patients tremendously. And so, yes, it's part of Lyme disease, maybe a little less than long COVID, but it's definitely part of it.
Gotcha. Got you. Dysautonomia and POTS for people that have had Lyme. So I imagine you're seeing that as well then?
Oh, yeah, absolutely. Yep.
Gotcha. All right. I've got two questions on ketamine. Are
No.
you seeing any of the institutions starting to look at ketamine research?
Yeah, so the clinical trials network that I mentioned to you that we're part of, that's coordinated out of Columbia, Dr. Brian Fallon, who's the PI at Columbia, is a psychiatrist, and one of the we provide seed money for pilot projects, and I think one of the projects is looking at ketamine actually.
Gotcha. Interesting. I think with that, we will wrap it up. We'll call it an evening. So very much appreciate you taking time. This was very, very informative. Look forward to staying in touch with you in the future, whatever that looks like. So for everyone watching, be on the lookout in February for having a virtual Lyme support group, open discussion, Q&A, sharing what's working, not working. So with that, we'll call it an evening. And Dr. Aucott, again, thank you very much.
It's my pleasure, and keep up the great work.
Yeah, you too. Thank you as well. Take care. Good night, everybody. Bye-bye.